Revita DMR is a catheter-based upper endoscopic procedure investigated in a multicentric prospective trial that uses a combination of circumferential mucosal lift and hydrothermal ablation to engender a healing of duodenal mucosa. The system is consisted of a console and one single-use balloon catheter serving as submucosal expansion and hot fluid ablation. The catheter is advanced into the duodenum over a guide wire.
The next case is a 44-year-old man presenting type 2 diabetes and overweight with oral antidiabetics medication, but with difficult diabetes control, as you can see, with the glycated hemoglobin at 8.2% with a normal range of 4 to 6%. So the patient is scheduled today for a duodenal mucosal resurfacing that will be performed by Dr. Devière and Costamagna.
We will demonstrate, I think, for the first time in life, this technique of duodenal resurfacing with this new device which aims to destroy the mucosa from the duodenum in order to allow a kind of reset of duodenal mucosa and a reset also of the enteroendocrine abnormality which may accumulate over time in patients with type 2 diabetes. The gentleman we are treating is part of a prospective trial, which is multicentric, and Guido, but also Horst, Neos, and Ralph Bishop are part of this multicentric trial. So I just would like to show you this interesting catheter. You see that it has a very nice taper tip, and you see that there is a balloon there, which is mounted with 3 catheters. And inside these 3 catheters, there is a small needle which can provide a submucosal injection. So when we are in place, we can lift the balloon. We can inflate the balloon. You see that the balloon becomes inflated, and then you may put the needle out, but you cannot see that, in order to perform the submucosal injection. Then you can further inflate the balloon if you want. That stage, after the injection, we can decide to have a hot fluid which will go through the balloon. And this hot fluid is at more than 80 degrees Celsius for a period of time which is well calculated, with a cooling, an eating period, and a post-eating cooling, in order to deliver a certain amount of heat to the duodenum and to induce the necrosis of the layer of the mucosa, while, thanks to the submucosal injection, preserve the risk of damage to the muscle layer. So this is the theory. We will see if it works in practice. You can deflate the balloon. We have placed in this patient already a guide wire in the first loop of the jejunum, Cincinnati, and we will try to advance the balloon together with an endoscope inside the duodenum.
As we said, we have placed a clip on the opposite side of the papilla. Through the scope, a guide wire is introduced in the first loop of the jejunum. Then the catheter is introduced.
You see also on the fluoroscopy that we have a clip there. This clip was placed, if you have the fluoroscopic image, just on the opposite side of the papilla, because of course the purpose here is to do a resurfacing from the genu inferius up to the triangle. I will continue to go alongside the lesser curve with a minimal pressure, but this new design allows to advance gently. You see that I do not make too much pressure. Maintenant, vous me remontrez le duodenum. And at this stage, when I think that I'm entering the duodenum, I will, of course, follow with the endoscope. But sometimes we can even pass through the genu superius without the help of the endoscope. So you see that here I'm just at close to the pylorus.
Yeah.
If you have the image there, I will try to push the two things together. You see, I'm advancing my endoscope, which is going alongside. I think that I've been a little bit too generous in the oil I've put on the catheter because I'm slipping on it. And I'm trying to advance here with the catheter. So you see that here the catheter is already almost in good position because we have a nice view on the clip. First ablation. So we are ready to the first ablation. So you can focus on the automatic machine there. We will inflate the balloon.
Alright, here we go. Inflating balloon.
So you should have a view also on the fluoroscopy now, and I hope that you have a view on the fluoroscopic image and on the inflation. So you see that the balloon is inflated. When it's fully inflated, I can suck as much as possible.
Sorry, injection.
And the needles are out, so we start the submucosal injection. So there is, I think, 40 cc's of saline with blue, which will be injected. And we will repeat a second injection because we want to have a submucosal injection which covers two segments. So we will do a second one and then start with the first ablation.
As we explained, before performing ablation, we realized some mucosal expansion. This picture illustrates mucosal lift. Here is the final result of submucosal expansion in the duodenum.
We will do the first ablation, so we will see the balloon which will inflate again. Now there is a warm-up. You see the temperature going up. When it will reach 86 degrees, we will be ready to have a pre-cooling and a post-cooling, and then the passage of the warm water inside the balloon.
Under endoscopic and fluoroscopic visualization, the balloon is inflated in order to allow the application of injection needle against the mucosa. We repeat a second injection. Then the same balloon delivers a hot fluid in order to achieve circumferential thermal ablation. The sequence includes 2 submucosal injections, followed by 1 ablation, and repeated 5 times proximal to distal.
To show you the end of the procedure, so this is in the setting of the protocol. So I did 5 ablation. We are approximately at the level of the trace angle. This is the end of the ablation, is to show you the result after this procedure. I think that the treatment we do in the setting of the protocol is still a little bit incomplete because we could ablate all the proximal duodenal part. But just to show you that it, indeed, with this beautiful picture with the Fuji colonoscope, which is very impressive in quality of image, you see the extent of the ablation and you realize that this is indeed a circumferential ablation which is performed from the genu inferius up to the triangle. You see that we have this necrose which is almost circumferential of the mucosa with some remnants of submucosal injection.